Once we have covered the vascular and the cellular events of inflammation, it is very essential to understand that how every step is mediated by a certain chemical and by a certain molecule. So what we need to know further in this particular chapter is what are the mediators of inflammation. Now, not only is this a very important topic for understanding the concept of inflammation, but because this has a lot of mugging up and a lot of cramming of terms and molecules, this tends to be one of those favorite topics with the examiners as well. Now, when we are talking about mediators of inflammation, I am going to divide them primarily into two groups. The first group is going to be the cell-derived mediators. Cell-derived. And the second group is going to be the plasma-derived mediators. Means the mediators that are circulating in the plasma. But they are circulating in the plasma. Where are they actually coming from? They are coming from the liver. So we have two categories, cell-derived and plasma-derived. Further, we are going to categorize this cell-derived category into two further parts. Either the mediators are preformed, that is, they are already present in the body, or they will be newly synthesized or newly formed mediators. So either the mediators are present beforehand, always present in our body, they just have to be released at the time of inflammation, or the mediators are going to be synthesized freshly, and once the inflammatory process begins, the enzymes are going, these particular molecules are going to get released. Now, once we have this broad overview, what we need to know next is the list of examples that we have. Preformed mediators include histamine, serotonin, and lysosomal enzymes. So histamine, serotonin and lysosomal enzymes are preformed mediators always present in our body. Next are the newly synthesized. Now what are the newly synthesized mediators? These include nitric oxide, platelet activating factor, arachidonic acid metabolites, which we will be talking about in detail, arachidonic acid metabolites. These in turn include prostaglandins. These metabolites include prostaglandins and LTs, that is leukotrienes. Further, we have cytokines and we have chemokines. So friends, nitric oxide, platelet activating factor, prostaglandins, leukotrienes, cytokines and chemokines. This is that extensive list that you need to know of the newly synthesized mediators. Now we have the plasma-derived category. So the best way of memorizing this category, students, is that all the similar sounding words come under this category. And once we make a list, you will know the meaning. This includes the kinin system, the clotting system, and the complement system. So all similar sounding, kinin, clotting, complement. All these three are going to fall under the category of plasma derived, ultimately being derived from the liver but circulating in the plasma. Now students, this is a brief overview of all the mediators that you need to know from the exam point of view. And to simplify and to memorize this table by getting back to it again and again, this is the same order in which we are going to discuss all of these mediators. So first I'll start with the cell-derived category. Under cell-derived, I'm going to take up the preformed mediators. Under the preformed mediators, we are first going to start and compare these two, that is histamine and serotonin. So let's begin with the first set of mediators, that is histamine and serotonin. Remember, these are cell-derived, preformed. First, let's differentiate them, then let's see what's common in them. Before I begin, I want you to recall one question that we had done. Who was the scientist who gave us histamine? We've discussed this right in the beginning of this chapter, which was the basic understanding when we were studying. If you can recall, then excellent. Histamine was given by Sir Thomas Lewis. Sir Thomas Lewis gave us histamine. Now students, let's first do all the differences. What is the source of histamine and serotonin? What is the source? So remember, histamine comes from mast cells. It also comes from basophils, and it also comes from platelets. So mast cells, basophils and platelets, these are the three cells you can say that are liberating histamine, but when you have a list, you must know the most important one. So which out of these three becomes the richest source of histamine? Remember, the richest source of histamine happens to be the mast cell. So the mast cell is the richest source of histamine, a direct one-liner question which is very important. Similarly, let's see what are the cells that are giving us serotonin. So serotonin is basically coming from first the GI tract, and in the GI tract it is coming from a cell known as the enterochromaffin cell. Enterochromaffin cell. Next, it can also come from the CNS as well as the platelets. Again, we have a list over here, GIT, CNS and platelets. So which out of this list becomes the richest source? The enterochromaffin cell. So remember that the richest source for serotonin is the enterochromaffin cell in the GI tract. So we've done two very important questions here. The richest source of histamine is the mast cell. The richest source of serotonin is enterochromaffin cell of the GI tract. After this, the next thing that we need to know now, what is their origin from? What amino acid are they originating from? So remember, histamine arises from histidine. Name is similar, histidine, histamine. Serotonin comes from something known as tryptophan. Tryptophan. Serotonin and tryptophan don't sound similar. Actually they do, because serotonin is also known as 5-HT. And what do we mean by 5-HT? 5-hydroxytryptamine. The other name for serotonin is 5-HT, 5-hydroxytryptamine. So histamine comes from histidine, serotonin or 5-hydroxytryptamine comes from tryptophan. So these were the two important differences that we have between histamine and serotonin. What comes next is the actual thing that we are concerned with, are the function. But the good news over here is that whether you're talking about histamine or you're talking about serotonin, the function of both is the same. And what are those functions? First, it is responsible for vasodilation. Vasodilation. But remember, there is a slight twist in the plot over here. Vasodilation is the usual function of both histamine and serotonin, but of the large vessels, like the arteries. It does not cause vasodilation, it causes vasoconstriction. It causes vasoconstriction. So there is one exception over here. Vasodilation usually, but the large vessels, vasoconstriction. The next mechanism is, the next function is that it is going to increase the vascular permeability. Histamine and serotonin both increase the vascular permeability. And the last function is that it is responsible for bronchoconstriction. A very important point that we have over here, students. Now we know that A person of asthma, you must have read multiple times that the underlying etiological mediator is histamine. Now you need to put that to practice. Histamine causes bronchoconstriction. That is why it has a role in asthma. So basically students, histamine and serotonin, quick review. Richest source of histamine is a mast cell. Richest source of serotonin is the enterochromaffin cell. The amino acid for histamine is histidine. The amino acid for serotonin or 5-hydroxytryptamine is tryptophan. Functions of both remain the same. Before we end our discussion on these two mediators, there is a small note that you need to keep in mind. Just now we spoke about a cell that is the mast cell. And what is mast cell the richest source of? It is the richest source of histamine. There is one question on the mast cell which tends to be a favorite with the examiners, that what is the special stain for a mast cell? What is the special stain? And let's understand this with the help of a diagram. So what image you see over here is, can you appreciate these multiple cells over here? These multiple cells over here. What do they have in common? They have these blue-purple granules. These are the mast cells, and the stain that is used for them is toluidine blue. The stain is toluidine blue. So students, this is one of those questions which is very frequently asked. Mast cells are stained by toluidine blue. The next question, students, that you can get, once you've understood mast cell releases histamine, mast cell is stained by toluidine blue, the next question is, how are the mast cells activated? What can result in the activation of the mast cells? So remember, the first feature or the first point by which mast cells can be activated, if this is a mast cell, for example, when it gets coated by these immunoglobulins, I hope everyone can recall this is the structure of an immunoglobulin. Particularly remember IgE. When they get coated by IgE, and IgE then undergoes polymerization. How will it undergo polymerization? When something comes and binds them. This is the antigen. So we have a mast cell that is covered all around by IgE. When an antigen comes and binds all the gaps between these IgE, what is it causing? It is causing polymerization of IgE. Polymerization of IgE. This then causes activation of the mast cell. So the first mechanism by which a mast cell can be activated is polymerization of immunoglobulin E. Remember, not just immunoglobulin E, but when they are connected by antigens, that is going to cause activation. That is when the mast cell will liberate histamine. The second way, this can also happen because of anaphylotoxins. Anaphylotoxins, examples include bee venom. This includes bee venom. This also includes another example of complement proteins. And how can you remember these complement proteins? So A for anaphylotoxins, C3A and C5A for anaphylotoxins. So all the A molecules, C3A, C5A, so A for the complement proteins, the subgroup A, and A for anaphylotoxins. So in response to anaphylotoxins also, the mast cells get activated. Third, a link that will bridge us and bring us to pharmacology, drugs. Drugs, for example, like morphine. Drugs, for example, like morphine, right? Drugs also, for example, like D-tubocurarine. morphine, DTC. That is why now students, when you go to pharmacology, you will see morphine is a drug that is going to be contraindicated in asthma. Why? Because morphine causes mast cell activation. Mast cell activation will release histamine, will worsen the condition of a patient of asthma. So we cannot give morphine in a patient of asthma. That is the very important MCQ that you get in pharmacology. Other than this, you also have a drug that is vancomycin. Now vancomycin, you will read, should always be given as a slow injection. Why not rapid? Because if given rapidly, it will result in mast cell activation. And what will be released? Mast cell activation will in turn result in the release of histamine. Histamine, as we all know, causes vasodilation, so will cause flushing of usually the upper body and the trunk, and that is known as the red man syndrome. So again, a link to pharmacology, 2 links to pharmacology that you have made over here. Morphine is that drug which is never given in asthmatic patients because morphine causes mast cell activation and more of histamine release. Vancomycin is always given as a slow infusion, not rapid, because if rapid, then mast cells will get activated, histamine will be released, and if histamine is released, there will be flushing in the body, and because flushing results in redness, they've given it a fancy name, that is the red man syndrome. So these are all the ways by which a mast cell can be activated. Now students, getting back to our flowchart that we had prepared, we have done preformed mediators, histamine and serotonin. Next we are going to go on to lysosomal enzymes. So what do we need to know about lysosomal enzymes? Let's begin with these. The third mediator we have is the lysosomal enzyme. Now remember that the lysosomal enzymes are present in cells, for example the neutrophils. They are coming from the neutrophils. Remember friends, neutrophils have 3 types of granules. Very important, a question and a topic that is usually missed out while preparing and while reading, but you should not do that. Neutrophil, if you're talking about the granules, there are 3 types of granules. Simple, that is primary, secondary, tertiary. No fancy names till now, primary, secondary, tertiary. The primary granule, students, is also known as the azurophilic granules. Azurophilic granules. These are the granules that are going to be present at which state? The promyelocyte. Now when we come to our discussion on the white blood cells, we will know that promyelocyte is one form of the precursor form in the bone marrow, and this is later on going to mature through a number of series and develop a mature neutrophil. So right in that initial stage of a promyelocyte, the granules that it has is a primary azurophilic granules. Secondary granules, so if we write this down, S for secondary, these are known as the specific granules. These are the specific granules. And which stage are they present from? They are present from the myelocyte stage. So primary are known as azurophilic, present in primary promyelocyte. Secondary, S for secondary, they are the more specific ones, they are present in myelocyte. Tertiary, now tertiary is written as 3. 3 is, how will we remember this? The third letter in the alphabet series is C. That is why the tertiary granules are also known as the C particles. Tertiary granules are also known as the C particles. C is the third letter in the alphabet chain, so tertiary granules, C particles. Now, if there are granules present in the neutrophils, they are going to then release certain enzymes. So, what are the enzymes that are going to come from the primary azurophilic granules? These include myeloperoxidase, MPO. Remember, we did this when we were doing phagocytosis, myeloperoxidase. This includes elastase, defensins, and collagenase along with cathepsin G. Now, how should we remember this? So, you can give this the mnemonic of Medical College. So, M for MPO, E for elastase, D for defensin, and two things with C, collagenase and cathepsin G. Also, it has a G, so cathepsin G. Next, we come to the secondary granules. Now, the secondary granules are going to liberate one very important molecule, that is going to be collagenase. Now, you will say that collagenase was also being released by the primary granules. Remember, those were azurophilic granules. These are specific granules. So, those were non-specific. These are specific. Those were releasing non-specific collagenase. This particularly releases type 4 collagenase. So, the specific granules will release a specific collagenase. The non-specific granules will release a non-specific collagenase. That is the way we can remember this. And lastly, the tertiary or the C particles will release gelatinase. So students, this is that table that is usually feared also and also left out with the fear of being not able to memorize. So we simplified this. We have three types of granules in a neutrophil. Primary, azurophilic. Secondary, specific, S for secondary, S for specific. And tertiary, third letter, tertiary is 3. So third letter in the alphabet, C, C particle. Primary granules release medical college. That is the mnemonic you need to remember. Secondary or specific granules are going to release specific collagenase, that is type 4, and tertiary is going to release the gelatinase. So with this we finished one very important category of cell-derived mediators, that is the preformed mediators. Now we are going to go on to the newly synthesized mediators. Under the newly synthesized mediator, the first one that we will take up will be nitric oxide. So let's begin our discussion now with nitric oxide. Okay, nitric oxide, there are certain points of nitric oxide, students, that you already know because we have discussed the vascular and the cellular events. What are those points that you already know? First is the formation. How is nitric oxide synthesized? We've done that. Nitric oxide is synthesized by an amino acid, that is arginine. So arginine in the presence of an enzyme nitric oxide synthase. I hope you can recall we had done this in phagocytosis. Nitric oxide synthase will give us nitric oxide and citrulline. So this is also a revision of our biochemistry. Arginine will give us nitric oxide and citrulline in the presence of nitric oxide synthase. We already know this. What are we adding to our knowledge here? Nitric oxide synthase is of three types. eNOS, where E stands for the nitric oxide synthase present in the endothelium. So endothelial NOS. The next is nNOS, where N stands for neuronal. So it is present in the neurons. The third is iNOS, where I stands for inducible. So nitric oxide synthase is of three types: E, N and I. E for endothelium, N for neurons, I for inducible. Nitric oxide synthase is a newly formed mediator. Which out of these three do you think is the enzyme that is resulting in its formation? E, N or I, and I hope everyone can understand that I inducible, it is going to be induced. So in inflammation, the NOS that is active, that is going to help us in formation of nitric oxide will be the INOS. Now we've done the formation. After the formation, let's discuss the function of nitric oxide. Let's discuss the function. Now nitric oxide, if we focus on the term nitric oxide, it has three very important functions that we need to consider. First is the X or the cross. It is going to kill the bacteria. So it is going to help in killing, or you can say it is going to help in phagocytosis. So it is going to kill. We've already done this. Nitric oxide in the presence of superoxide forms peroxynitrite. This is going to cause phagocytosis. We've discussed this under a discussion of phagocytosis. What is with I? It is going to inhibit platelet aggregation. It is going to inhibit platelet aggregation. And lastly, what is with D? One very important concept. It causes vasodilation. Now questions out of these tend to maximally come on the concept that nitric oxide is causing vasodilation. Why? Because of nitric oxide causing smooth muscle relaxation. Now what happens is that the blood vessels are lined by this muscle coat. The muscle coat is the smooth muscles are going to relax. When the smooth muscles relax, the vessel is going to dilate, increase in diameter. How does this happen? So this is one of the most asked mechanisms of nitric oxide. One of the high yield questions comes from these. So let's understand that nitric oxide is going to increase the concentration of something known as guanylyl cyclase. This in turn increases cyclic GMP, and this in turn is going to result in smooth muscle relaxation. Now students, this cyclic GMP can further be degraded. It can be degraded into its metabolites by an enzyme called phosphodiesterase 5. Phosphodiesterase 5. Why are we dealing with this entire mechanism? Nitric oxide, by increasing cyclic GMP, is going to cause smooth muscle relaxation, and by causing smooth muscle relaxation, it is going to cause vasodilation. Now, for example, let's take the main use of the drugs or link this to pharmacology and understand why we need to know this pathway. For example, there is a person suffering from impotency. A person suffering from impotency, the drug that is given, that everyone knows, is a phosphodiesterase 5 inhibitor, that is sildenafil. So the treatment given to such a patient is sildenafil. Now if you know the mechanism or this pathway, you know why. If sildenafil is given, phosphodiesterase 5 is going to get inhibited. Will cyclic GMP now get degraded? No. There will be more of cyclic GMP, means more of smooth muscle relaxation, means more of vasodilation. More of vasodilation means that the blood flow to the sexual organ is then going to increase, and the problem is thereby solved. So that is the reason that sildenafil, which is a phosphodiesterase 5 inhibitor, is given in patients of impotency. The underlying mechanism and the concept lies in this particular nitric oxide. So students, for nitric oxide, we've done a very important mnemonic. First, it is going to cause X or cross, kill the bacteria. Next, it is going to inhibit platelet aggregation. Third, it is going to cause vasodilation by smooth muscle relaxation. So this is the very first and the important mediator that we've done. We have finished with nitric oxide. Now let's go on to the next, that is platelet activating factor. So students, the next mediator that we have is the platelet activating factor. It's in the name, it is going to activate the platelets. It is platelet activating factor. Now this platelet activating factor comes from which particular cell? So there is a wide variety of cells from which it can come. It can come from the mast cells. It can come from the basophils. A wide variety of cells liberate platelet activating factor. What does this platelet activating factor do? It causes platelet aggregation and it causes vasoconstriction. So it is going to aggregate the platelets, it is going to constrict the blood vessels, that is platelet aggregating factor. Remember, this is one of the most potent mediators we have. If you've considered histamine as the prototype, and mostly everywhere histamine comes in role, but approximately 1000 times more potent than histamine is also a platelet activating factor. This is one of the most potent inflammatory mediators that we have in our body. So coming back to our list, we have finished the first two newly synthesized mediators. Now we go on to the next category, which is definitely an important one, arachidonic acid metabolites. And students, not only is this important here, but if you do the pathway once over here, a number of drugs of pharmacology will also be covered side by side. So let's finish off the pathological and the pharmacological aspect clubbed in one particular flowchart. So beginning with arachidonic acid metabolites. The first thing you need to know, what is this arachidonic acid? And then later on we will discuss what are the metabolites. Now the first question that is asked, which actually is a question of biochemistry, and the question that is asked is that arachidonic acid is going to have how many carbon compounds? So remember, it is a 20 carbon compound. It is a 20 carbon compound. What is it coming from? Very rarely you must have heard of arachidonic acid being present in the body. So remember that the precursor is the phospholipids. Particularly remember, very important, it is coming from the linoleic acid. Now when phospholipids are broken down, if you want to break phospholipids, what will be the enzyme that you will use? Lipids broken by lipase. So phospholipid broken by phospholipase A2. This is the enzyme that is needed to break down phospholipid into arachidonic acid. So we've reached arachidonic acid. Arachidonic acid is having how many carbon compounds? We just discussed, very important question, it is 20 carbon compounds. Next, what we need to know, this arachidonic acid can then take up multiple pathways. Now students, usually most books just mention 2 pathways, but actually arachidonic acid can undergo 4 pathways, and these rarer pathways are now becoming potential questions for the future exams. So arachidonic acid can either take the pathway where it is going to be acted upon by enzyme COX. What is COX? It stands for cyclooxygenase. It will result in the formation of prostaglandins. The second pathway It can be acted upon by an enzyme called LOX, that is lipooxygenase, resulting in the formation of leukotrienes. The third pathway, it can also be acted upon by cytochrome P450 epoxygenase, resulting in formation of two molecules, that is EET and HETE. And lastly students, there is one last pathway that is very rarely covered, that is known as the isoicosanoid pathway. Where there is formation of isoprostane. Now, with so many new terms, please do not get too confused. We are going to take each of these pathways in detail, and this will help us in memorizing them. So, we are first going to see what happens when arachidonic acid enters the COX pathway. So, let's take this as arachidonic acid, and it is being acted upon in the COX pathway, that is cyclooxygenase. When it is acted upon by the enzyme cyclooxygenase, what does it have to form? Please recall from this chart, prostaglandins. The first prostaglandin that is synthesized is PGG2. After G, the next alphabet is PGH2. So PGG2 is the first, the next in order is H, so PGH2 is the next. After that, there is synthesis of the next alphabet, that is PGI2. So G, H and I. Remember, PGI2 is also known as prostacyclin. From this PGH2 came PGI2, and from this PGH2 only will come the rest of the molecules. These include TXA2 or thromboxane A2. Also, whatever alphabets were left, like PGD2, E2 and PGF2 alpha. So, whatever alphabets were left before that, D, E, F, they are going to come down now. So, this is a brief summary. Arachidonic acid is acted upon by cyclooxygenase. It forms the first prostaglandin, that is PGG2, next alphabet H2, next alphabet I2. But from the same H, we also have D, E and F, and we have thromboxane A2. Now students, there is not only the mechanism or the pathway that is important, their functions are also important. When we are dealing with these two, why I've put them together is, whether you read prostacyclin or you read thromboxane A2, read any one, remember any one, because the other is the complete opposite. They are complete opposites of each other. First of all, prostacyclin is going to be released from the endothelial cells. This comes from the endothelium cells. Thromboxane A2 on the other hand comes from the platelets. That is the first difference. The second is in their function. If you focus on the term PGI2 or prostacyclin, I for inhibition. So this is about the origin of these, prostacyclin from endothelial cells and thromboxane A2 from the platelets. What is different in the function? Now focus on the term PGI2. PGI, I stands for inhibition. So this is going to inhibit platelet aggregation. And I told you that thromboxane A2 is the complete opposite. Also it has the term or it has the letter A. So this is going to in turn cause platelet aggregation. This in turn is going to result in platelet aggregation. So we have prostacyclin which has PGI2, I for inhibition, so it will inhibit platelet aggregation. Thromboxane A2 on the other hand has the letter A, So A stands for aggregation. So this is going to stimulate platelet aggregation. After that, the next difference is that prostacyclin is released from the endothelial cells and it is going to result in vasodilation. So what will thromboxane A2 be? The complete opposite. Thromboxane A2 will result in vasoconstriction. So students, you just need to remember any one of these and the other one becomes the complete opposite or the antagonistic action. Prostacyclin is going to inhibit platelet aggregation, is going to cause vasodilation. So thromboxane A2 becomes the complete opposite, platelet aggregation and vasoconstriction. So these are three very important MCQs that have been asked in the previous years as well. Now going to the third set that comprises of D2, E2 and F2 alpha. All three of them have some functions which are common. And how will we remember these? By the 3 P's. They are going to have 3 P functions. That is pain. The first P is for pain. As we've already discussed, inflammation is associated with pain. The second is, we all know when we have an infection, there is fever. So we will term that as pyrexia. That happens to be the second P. And the third P is for permeability. So an easier way of remembering is that these three molecules D2, E2, F2 alpha will have a 3P action of pain, pyrexia and permeability. So these 3 P's are common to these 3 molecules, but out of these 3, the one that is maximally associated with pain is PGE2. This PGE2 is said to be responsible for hyperalgesia. Hyperalgesia means more of pain. So that is what is making it different from the rest of them. Also, one thing that links us with obstetrics over here is PGF2 alpha is one particular molecule for which certain drugs are present, like dinoprost, carboprost. Why? Because this causes uterine contraction. This increases uterine contraction. That is why in obstetrics, drugs are given for this, simulating the action of PGF2 alpha. So students, this was an entire summary of the arachidonic acid taking the cyclooxygenase pathway. Please keep this in mind because with the same pathway, there are certain pharmacological links that can be dealt with. You need to focus on this enzyme COX. And now let's see why. When you're dealing with COX or cyclooxygenase, remember that COX is of 2 types. Cyclooxygenase type 1 and cyclooxygenase type 2. Amongst this, remember, COX1 is constitutive, means it is present in almost all normal tissues. For example, it is present in the stomach, it is present in the platelets. COX2, on the other hand, has a more limited distribution. It is present in the endothelial cells. It is present in the endothelial cells. Why are we doing this in detail? For example, you want to stop the inflammatory process, so you give a COX inhibitor. You give a COX inhibitor, that is NSAIDs. Non-steroidal anti-inflammatory drugs, these are COX inhibitors. Now remember, there are 2 categories. One are going to be, for example, aspirin. That is going to inhibit COX1 also and COX2 also. So both COX1 and COX2 inhibited, the mediators will not be formed, anti-inflammatory action will set in. But remember, COX1 was present in the stomach. Remember, COX1 is not only present in the stomach, it is also gastroprotective. It is protecting the stomach. Now, if I give a drug which inhibits this protective action, what will the patient suffer from? The patient will then suffer from gastric or peptic ulcers. Again, one of the most common side effects of aspirin is peptic ulcers. Why is that so? Because aspirin inhibits all forms of COX, both COX-1 and COX-2. COX-1 is gastroprotective, so COX-1 inhibition will result in peptic ulcers. So then the pharmacologists have come up with selective COX-2 inhibitors. Selective COX-2 inhibitors like celecoxib and meloxicam. They will only inhibit COX-2. They will not have any role on COX-1. Thus, they will not make the patient suffer from any type of peptic ulcer or gastric ulcers. But students, there is one thing that you need to know over here. They are inhibiting the COX-2, right? So, if you know, COX-2 was present in the endothelial cells. Endothelial cells were secreting one very important mediator. If you go back to this particular flowchart, from the endothelial cells, we have prostacyclin. So what is selective COX-2 inhibitor doing? If it is inhibiting the COX activity in the endothelial cells, there will be no prostacyclin now. Okay, so coming back, because it is inhibiting the endothelial cells, there will be a decrease in the prostacyclin. Meanwhile, COX-1 is functioning well. COX-1 was present in the platelets. Platelets are producing thromboxane A2. Thromboxane A2 levels are then going to increase. Why? Because COX-1 is functioning normally, platelet activity is normal, thromboxane A2 production is normal. But prostacyclin synthesis has gone down. Both of them were antagonists. They were creating a balance, but that balance has been disrupted. Now we have more of thromboxane A2 and less of prostacyclin. Remember, thromboxane A2 was causing platelet aggregation. Thus, we can say that these patients are at a very high risk of certain cerebrovascular accidents, cerebrovascular diseases. So, the complications in this are no less. It is not that selective COX-2 inhibitors will not result in any complication. You need to see the clinical profile of the patient. COX, if the drug is inhibiting all COX enzymes, patient will land up in peptic ulcers. If the drug is inhibiting only COX-2, there is a risk of cerebrovascular complications also, because there is a lot of platelet aggregation that is taking place. So we need to weigh the clinical profile of the patient and assess on the basis of the past history that which drug will be more suitable for that particular patient. So students, this was the first type of pathway that arachidonic acid can take, that is the cyclooxygenase pathway. The next type of pathway that arachidonic acid can take, as we had discussed, will be the LOX pathway. What is the full form of LOX? It is the lipooxygenase. It is the lipooxygenase pathway. So LOX stands for lipooxygenase. I am adding one number in front of it. It particularly uses 5-LOX. Now, when arachidonic acid is acted upon by 5-LOX, the first thing that develops or that is produced are leukotriene, and that is leukotriene A4. What was the first prostaglandin that was produced? PGG2. What is the first leukotriene produced? Leukotriene A4. Starts with A, the first one is A. From this leukotriene A4 results the next leukotriene, that is leukotriene B4. And from this only there is synthesis of C4, leukotriene D4 and leukotriene E4. Now students, what you need to know is that leukotriene A4 is that common point from which we are having B4 also, and on the other hand we are having C, D and E as well. Now, is there any step of inflammation where we had read leukotriene B4? Yes, remember we did a mnemonic LIC for chemotactic agents. Over there, leukotriene B4 was the L. These are chemotactic agents. They are going to help in chemotaxis. Next, we have a list of these C4, D4 and E4. Remember, these are very important. They are also named as SRSA, that is slow reacting substances of anaphylaxis. Now, slow reacting substances of anaphylaxis, these are the ones that are going to be responsible for bronchoconstriction. They are resulting in bronchoconstriction. Now, what students we need to know over here? This was 5-LOX pathway forming leukotrienes. If I want to inhibit this pathway, what are the drugs that I can use? So, we come to the pharmacological aspect. First of all, I can use a LOX inhibitor. If the enzyme activity is lost, if this enzyme is inhibited, I can attain that the rest of the pathway will not occur. This is by giving a drug that is Zileuton. The other way of stopping this pathway is that I do not touch the lipoxygenase, I let the pathway function as it is, but in the end, I've just discussed C4, D4 and E4. They are going to cause bronchoconstriction. How? They are going to go and, for example, if this is the pulmonary or the bronchial airway, they are going to act on certain receptors. So they are going to come and act on certain receptors known as leukotriene receptors. So what am I going to do? I am going to block this. Or in other words, I can give the patient leukotriene receptor antagonists. So something else will come and bind to these leukotriene receptors, as a result of which the leukotrienes will not be able to bind with them. And these group of drugs are what are very commonly prescribed, like montelukast and zafirlukast. Montelukast and zafirlukast, very commonly prescribed drugs that we have. These are nothing but leukotriene receptor antagonists. So if we have to revise, the arachidonic acid can take a lipoxygenase pathway, to be precise the 5-lipoxygenase pathway, that can form leukotriene A4 followed by B4. B4 is a chemotactic agent. A4 further forms C, D and E. These are going to have a role in asthma because they cause bronchoconstriction. So if we want to inhibit this pathway, either we are going to inhibit the particular enzyme, that is 5-LOX, by the drug Zileuton, or we are going to inhibit the receptors by drugs that is montelukast and zafirlukast. Now students, this pathway does not end over here. The same arachidonic acid can take another pathway. Again, it will use the enzyme LOX, but now the LOX has changed. Now it uses some other variant of LOX and results in the formation of lipoxins, particularly lipoxin A4 and lipoxin B4. Now why do we need to know this? Because lipoxins are those molecules, and one of the very few molecules that we have, which are going to have an anti-inflammatory action. So till now we were discussing all the mediators which were going to promote inflammation. This is that mediator which is going to stop inflammation. This also comes via lipoxygenase. Not 5-lipoxygenase, there are other lipoxygenases like 12 and 15. It takes another route. These are formed. These are not pro-inflammatory. Remember that these molecules are anti-inflammatory. So this was the second pathway that arachidonic acid was taking. Now I told you that as such there are actually 4 pathways, and the third and the fourth ones are the ones that we don't tend to cover a lot and we tend to escape. So let's see what do we need to know in those. Arachidonic acid can take a third pathway in which it will be acted upon by cytochrome P450 epoxygenase. Cytochrome P450 epoxygenase, resulting in the formation of two things. One is known as EET, Eicosa tetraenoic acid. The full form is not needed. The other is HETE, hydroxy-Eicosa tetraenoic acid. The full form is something you don't have to focus on. It is the function. Remember, HETE is going to cause renal vasoconstriction. Renal vasoconstriction. Because it causes renal vasoconstriction, it is going to result in hypertension. On the other hand, EET is a complete opposite. EET on the other hand is going to have anti-hypertensive properties. So students, what you need to remember, this cytochrome P450 epoxygenase pathway will produce two things, EET and HETE. Out of these, HETE has the word H, so this is what is going to result in hypertension. EET is the opposite, that is, it is anti-hypertensive. The last and the fourth pathway that arachidonic acid can take is known as the iso-eicosanoid pathway. And thankfully, this pathway does not have any enzyme. This is the only pathway which is non-enzymatic. The conversion of arachidonic acid till now either was because of COX, or was because of LOX, or was because of cytochrome P450 epoxygenase. But now it is not because of an enzyme, and this non-enzymatic conversion results in the formation of isoprostanes. Isoprostanes. Remember students, isoprostanes have P. They are going to result in platelet aggregation. They have a role in platelet aggregation. So students, if we have to sum up, arachidonic acid metabolites that we did, very important for pathology as well as for pharmacology. Arachidonic acid can take primarily four routes. First, the COX pathway. It will result in the formation of prostaglandins and thromboxane A2. Second is the LOX pathway. It will result in the formation of leukotrienes, which are pro-inflammatory, and lipoxins, which are anti-inflammatory. Third is the cytochrome P450 epoxygenase pathway, where we are going to have two molecules, EET, which is antihypertensive, and HETE, which is hypertensive. Lastly, we have a non-enzymatic method in which there is going to be conversion of arachidonic acid into isoprostanes, which are going to be P for prostanes, P for platelet aggregators. So this, if we get back to our list, this was all about the arachidonic acid metabolites. All throughout, we have also discussed their pharmacological roles. But what if you wanted to stop the process at the very first stage, the last drug that you need to know over here? If I don't want arachidonic acid to be synthesized at the first place, if you recall, arachidonic acid was coming from phospholipids. Phospholipids were being broken down by an enzyme, that is phospholipase A2, into something known as arachidonic acid. So if I don't want this arachidonic acid to be synthesized at the first place, I am going to inhibit this enzyme, and the drug that is given is steroids. Steroids are going to inhibit phospholipase A2, and thus the entire pathway is going to be stopped even before the synthesis of arachidonic acid. So coming back to our list, we've done three very important newly synthesized mediators: nitric oxide, platelet activating factor, and arachidonic acid metabolites. The next ones that we go to are cytokines. The next set of mediators that we are going to begin with are under the same category of newly synthesized or newly freshly formed mediators, and these are the cytokines. So students, what are the important points that we need to know about cytokines? And before we go into that long and most extensive list that we have under inflammatory mediators, I want to tell you two important definitions. There is something known as pleiotropy and another term known as redundancy. And what do we mean by this? One cytokine can have multiple actions. So for example, there is cytokine A. This can have multiple actions. That is known as pleiotropy. Redundancy means, on the other hand, that there are many cytokines like A, B, C, just random alphabets, and all of them are going to have the same action. So one cytokine can have multiple actions, that is pleiotropy. Many cytokines might have the same action, that is known as redundancy. Now, what are the categories of cytokines that we are going to deal with? The first set of cytokine students that we have is interleukin IL. That is how we abbreviate it, is of interleukins. The second that we need to know is TNF alpha, that is tumor necrosis factor alpha. Tumor necrosis factor alpha. And the third is interferon gamma. Interferon gamma. So these are three categories that we have. Now students, there is one group that I am going to form of interleukin 1, IL-1, interleukin 6, that is IL-6, and TNF alpha, tumor necrosis factor alpha. I am going to form this one group right now because this group of cytokines has a common action. And what is that action? So on the central nervous system or the brain, whenever we have any infection, there are some features that are experienced by all. Infection causes fever. Infection causes decrease in appetite. There is lethargy. So all of these are because these interleukins are acting at the neurological level, at the CNS level, causing fever, lethargy and decrease in appetite. Other than this, remember, the same set of mediators, that is interleukin 1, 6 and TNF alpha, can also act on the bone marrow. Everyone is already aware of the concept that in an infection, there is an increase in the total leukocyte count. Why is there an increase? Because these mediators or these cytokines, these three cytokines are going to act on the bone marrow. And lastly, the same set also goes and acts on the liver. One of the most important actions. In the liver, it results in the formation of APR, also known as acute phase reactants. Also known as acute phase reactants. Now, when these interleukin 1, 6 and TNF alpha, they act on the liver, either they will increase the synthesis of acute phase reactants, we will call them positive APRs, or they might decrease the level of some acute phase reactants, we will call them negative APRs. Now, positive APRs will include fibrinogen, CRP, serum associated amyloid. It will also include, apart from these three, why have I written these three as the topmost? Because these three are the most important on which the questions have come. But other than this, they also increase hepcidin, and ferritin. So these are lower down in the list but definitely important. Hepcidin and ferritin are also going to be elevated. So fibrinogen, CRP, SAA. And please recall, CRP was C-reactive peptide, in which the C was standing for capsular polysaccharide of pneumococcus. Now going to the negative APRs, which are the acute phase reactants, the levels of which are going to decrease. And these are going to include, first of all, this will include albumin. So this is a question that has been asked in the previous years. What you need to know, the level of albumin is going to go down. Also its precursor, that is prealbumin, that is also going to go down. So that is very important to know. And also we have transferrin. So you can remember TAN, T for transferrin, A for albumin, and N for negative acute phase reactants. So overall, if you want to summarize the cytokines till now, we have made a group of 3: interleukin 1, interleukin 6 and TNF-alpha. They have some common actions, that is why we brought them up together. Interleukin 1, 6 and TNF-alpha will act on the brain, resulting in features like fever, decrease in appetite. They will act on the bone marrow, resulting in increase in the total leukocyte count. They will act on the liver, and they will either increase the APRs like CRP, fibrinogen, or decrease the APRs like transferrin and albumin. Now out of these, we need to focus on one particular cytokine separately, that is TNF-alpha. Now why do we need to focus on this? Because TNF-alpha, so A for alpha, this is the main cytokine that is responsible for a decrease in the appetite. So A for alpha, A for appetite. So what actually we refer to as, everyone has heard of cancer cachexia. Like in cancers or in extreme malnutrition, there is cachexia when the person becomes extremely thin and is said to be cachexic. What is that cachexia mediated by? That cachexia is mediated by TNF-alpha. So A for alpha, A for appetite. This particular set is very important to know. Now before we proceed to other particular interleukins and cytokines that we have, there is one mention that we need to make over here. We had discussed that people, whosoever has an infection, will have fever. Fever can be because of two types of products. Either the exogenous products or because of endogenous products. Exogenous meaning the bacterial products themselves, and endogenous will include interleukin 1, interleukin 6, TNF-alpha. There is a long list, but these are the most important ones that you need to remember. After that, what we need to know, that when there is a person who is under the effect of all these cytokines, right, there is something known as SIRS, that is systemic inflammatory response syndrome. Systemic inflammatory response syndrome, SIRS. And when do we diagnose this syndrome? When 2 or more than 2 of the following are present. And what are those? First, the body temperature, either more than 38 degrees Celsius or less than 36 degrees Celsius. So the first criteria is the body temperature. The second criteria becomes the respiratory rate. If it is more than 20 per minute. The third is the heart rate, if it is more than 90 per minute. Right? So these three are the most important actually, that is temperature, respiratory rate as well as heart rate. Other than this, what we need to know, that in systemic inflammatory response syndrome, It is actually a syndrome, so we are going to have multiple other features. But when we talk about these three, we are talking about the clinical side. What about the pathology side? So the total leukocyte count, when more than either 12,000 per millimeter cube or less than 4,000 per millimeter cube. With, students, one point that everyone forgets, more than 10% band forms. Now, whenever there is any infection, the first cell that is released amongst the precursors, that is released more in the peripheral blood, happens to be the band cells. It is just one step before a mature neutrophil. So this is that, remember, more than 10% of band forms present in the peripheral blood with either a total leukocyte count of more than 12,000 or a TLC less than 4,000 is very important. And remember, out of these four, when 2 or more than 2 are present, we will diagnose a patient as having systemic inflammatory response syndrome. Then how do you differentiate it from sepsis? Very commonly used term, patient has gone in sepsis. That is nothing but SIRS that we just discussed. Along with, there should be some documented evidence of infection. If there is a documented evidence or a foci of infection, then you can label it as sepsis, documented evidence of infection. So if there is no documented evidence of infection, you will label the patient as SIRS. If there is an evidence, you will label the patient as sepsis. The question that comes, what is the marker of sepsis? What is the marker of sepsis? Earlier it was said to be CRP, C-reactive protein. But now we have a new marker, and this also has come as a question. This is procalcitonin. Procalcitonin is a new marker of sepsis, which you need to remember. This has been asked as a question previously and is one of the definite expected ones in the coming exams. So this is all about how fever can happen in response to the interleukins that are being released in inflammation, the mediators that are being released in inflammation. Primarily, we were dealing with interleukin 1, interleukin 6 and TNF alpha. Now what we need to do, we need to make a list of all the cytokines. We need to make an important list of the cytokines which are important for us, the functions of which we need to know for the exam. So first, we have interleukin 1. We just discussed interleukin 1, interleukin 6, TNF alpha. We know everything about these now. Next, we have interleukin 2. How will we remember the function? Interleukin 2. Between two things only it is going to juggle. What do I mean by that? Interleukin 2 is basically produced by the T cells. So T cells will produce interleukin 2. And what will interleukin 2 in turn go and do? It will have an autocrine effect. It will have an autocrine effect on the T cells. So it will then stimulate the T cell to further release more of interleukin 2. So it's just juggling between these two things. T cells produces interleukin 2. Interleukin 2 goes back and stimulates the T cells to produce more of interleukin 2. So that is how you'll remember IL-2. The next one that we need to know is interleukin 4 and interleukin 5. Now all of us know that how the B cells are going to mature into plasma cells, and further that is going to produce immunoglobulins. Now this is well versed with everyone. But what is going to cause this B cell maturing into or converting into a plasma cell? It is going to be interleukin 4 and 5. It is going to be interleukin 4 and 5. So interleukin 1, you know already. Interleukin 2 has an autocrine effect on T cells. 4 and 5 are when the B cells are going to produce plasma cells and immunoglobulins. The next in the list is interleukin 6, which again you already know because we had a list of interleukin 1, interleukin 6 and TNF alpha. Then we have the next interleukin that you need to know, which is an important one, students. interleukin, again 7, which is not very well studied, but it is important. Interleukin 7 is needed for the normal B and the T cell maturation. Interleukin 7 is needed for the B and T cell maturation. If interleukin 7 is defective, this can result in an immunodeficiency condition that we will be reading in the chapter of immunity, severe combined immunodeficiency disease. SCID can occur when there is interleukin 7 defect, because in that the maturation of the B and the T cells is going to get affected. Next, students, what I want you to focus on is interleukin. We've done up till 1. We are not taking up every particular number. We are going to take up limited numbers so that we can memorize them, because we cannot do the entire list, nor is the entire list important for us. After this, what we need to know is a very important interleukin, that is interleukin 10. What is so important about 10 is that this particular interleukin is anti-inflammatory. Till now, all of the conditions that we were doing were pro-inflammatory, all the mediators were pro-inflammatory. This is anti-inflammatory. Once we finish our discussion on this, we will make a list of all the anti-inflammatory molecules that we have. Lastly, interleukin 11. Interleukin 11, that is the interleukin that is needed by the megakaryocyte for the production of, yes, you're right, megakaryocyte is the precursor of platelets. So students, this happens to be one of the toughest lists that you have to remember, but the only key to remembering this is that you have to revise it again and again. And unfortunately, even now this list is not over. I've kept certain questions after this list because those are the high yield and most important ones that you ought to know in this particular topic. So let's deal with certain very important MCQs. Question number 1. Is there any cytokine which is going to have both pro-inflammatory action as well as anti-inflammatory action? So remember, interleukin 4 and interleukin 6, they are going to have both pro-inflammatory and anti-inflammatory action. Question number 2. In question number 2, if you are asked, is there any cytokine which is going to have only and only anti-inflammatory action? So we just did a list of cytokine, one particular actually, that was interleukin 10, which had only anti-inflammatory action. 4 and 6 also have anti-inflammatory action, but they also have a pro-inflammatory action. So they can act as per the need of the body, but 10 has solely an anti-inflammatory action. Other than this, interleukin 13 as well as TGF beta, transforming growth factor beta. Are there any other molecules that we have already read which have an anti-inflammatory action? Something in the arachidonic acid pathway? Yes, when there was conversion of arachidonic acid by lipoxygenase into something known as lipoxins. So all of these are anti-inflammatory. The next question that we need to know, which is the most fibrogenic cytokine? The most fibrogenic cytokine, and the answer to this is TGF beta. This is the most fibrogenic, which induces fibrosis. The next question that we have, which is the mediator associated with angiogenesis? Which is the mediator associated with angiogenesis? This is a simple one, that is vascular endothelial growth factor. Vascular endothelial growth factor, very important for angiogenesis. The next question in this category that we have, which out of these is the most important cytokine? Which out of these is the most important cytokine for causing fever? For causing fever. First, for decrease in appetite. for decrease in appetite, for ये 2 लाइन फिर पहले करके फिर बोल देते हैं. The next question that we need to know is, which is the most important cytokine that is going to be responsible for a decrease in appetite, for the development of fever, and for the synthesis of acute phase reactants. So remember, for appetite it was TNF alpha. For appetite it was TNF alpha. Remember, for fever we had interleukin 1, interleukin 6 as well as TNF alpha, right? Out of these, interleukin 1 plays a very important role when it comes to fever. And acute phase reactants are usually synthesized in response to interleukin 6. These are the important MCQs that you need to know for this particular topic. Now students, right in the beginning when we started this particular discussion, we said that cytokines can be interleukins, they can be TNF alpha, and there can be one category known as interferons. Category of interferons. So what do we need to know about interferons is that interferons can be of 3 types: interferon alpha, beta and gamma. How are they being produced? The mnemonic for this is LFT, or liver function test. Interferon alpha is going to come from the leukocytes. Interferon beta is going to come from the fibroblasts. And interferon gamma is going to come from the T cells. So simple: alpha, beta, gamma, LFT, they are going to come from the leukocytes, the fibroblasts and the T cells. What are their functions? Leukocytes release interferon alpha, so A for alpha, and this has antiviral properties. So if you want to treat any viral infection, which particular interferon would you want to elevate? Interferon alpha, because interferon alpha has antiviral properties. Interferon beta is coming from the fibroblasts, right? And this basically has an immunomodulatory effect. This has an immunomodulatory effect. In fact, interferon beta therapy is very commonly prescribed for a disease that is multiple sclerosis. That is multiple sclerosis. And lastly, and the most important in this category, interferon gamma, which is coming from the T cells, this is going to cause macrophage activation, resulting in the formation of a granuloma. Now students, G for gamma, and G for granuloma. That is how we will remember. So to overall, if you want to summarize, interferons are of 3 types: alpha, beta, gamma. Alpha, A for antiviral properties. B for beta, B something to do with the brain, multiple sclerosis. G for gamma, G for granuloma formation. So I hope with this particular way or trick of memorizing, you will be able to retain this for a longer time. Another mnemonic: alpha, beta, gamma, LFT, leukocyte, fibroblast and the T cells. So students, with this we have now come to the last mediator in this particular section of newly synthesized, that is the chemokines. We are now going to begin our discussion about the chemokines. Now there is a similar sounding word that we have read earlier also when we were doing chemotaxis, means it is going to attract the WBC. The WBC is going to move towards the bacteria. That is carried out by certain chemotactic agents. Similarly, the same chemokines over here, they are also going to be nothing but extremely small protein molecules. They are also going to act as chemoattractants. They are going to attract the WBCs. Now this is again one of those tables which needs to be mugged up because it has certain terms and it has certain new words actually that you just need to mug up. So we'll just make that table first. Chemokines fall under 4 categories. The first category is known as CX3C. The other is CXC. Third is CC. And the fourth is C. So what is this C and what is this X before we proceed? Wherever they talk about C, it means cysteine residues. C will refer to cysteine residues. X on the other hand means any amino acid. It is any amino acid. So no amino acid in particular, it can be any amino acid. So this is the full form of C and X. So the first category was CX3C, means it has 2 cysteine residues and 3 amino acids. Next, keep on reducing the X molecules. CXC has 2 cysteine, 1 amino acid. CC has just 2 cysteine, no amino acid. And C just has a single cysteine and no amino acid. There are certain other names also that have been given. Forget the first category. Start from the second. This is known as alpha chemokine. The CC is known as beta chemokine. And C is known as the gamma chemokine. So just eliminate the first category of CX3C. The remaining become alpha, beta and gamma. Now there are 2 set of differences you need to do for this table. First, which cell is it going to attract? It is a chemoattractant, so it will attract some cell. Which cell will it attract or which cell will it help in the movement of? Other is what are the examples. So these are the 2 things you need to know. CX3C is mainly for the mononuclear cells. Example, the monocytes and the T cells. And an example of this is something known as fract alkene. Fract alkene is an example of CX3C, which is going to attract the monocytes and the T cells, or in other words, simplified mononuclear cells. Example, fract alkene. Next we have CXC or the alpha chemokine. This is going to attract all the WBCs that we have. This is going... एक सेकंड दोबारा कर रही हूँ. The next category is CXC. Now this particular chemokine is mainly for the neutrophil. It is going to attract the neutrophils. And the example that we have under this category is interleukin 8. Now students, wherever in pathology or any subject you come across interleukin 8, automatically consider that neutrophils will come hand in hand. That is how the association goes. Interleukin 8 will be a chemokine for neutrophils. So it will recruit the neutrophils. The next category is CC or beta chemokine. Now we have one chemokine just for the neutrophil. So in the next category, we are going to have all WBCs except the neutrophils. Except the neutrophils. So for example, this particular chemokine will attract, an example is Rantes. You do not need to go into the full form, but remember Rantes has the word, the letter T, so this will attract the T cells. Next example, MCP1. It has the letter M, so this will be for a monocyte. Third example, eotaxin. This has the letters EO, so this will be for an eosinophil. So basically, these are for all the WBCs except the neutrophils, because for neutrophils we had CXC. CXC example was interleukin 8. And the last finally that we come to is the gamma chemokine, and this is going to mainly attract the lymphocyte. This is going to attract the lymphocyte, and because it attracts the lymphocyte, the name is very simple, it is lymphotactin. So students, as I had told you, this happens to be one of the most difficult tables that we have under mediators. How to simplify? 4 categories. C and X refer to C for cysteine, X for amino acid, any amino acid. So 4 categories. Number 1, we have CX3C, the longest name. The example is the longest, that is fract alkene. It will bring the mononuclear cells. Next is CXC, also known as alpha chemokine. This is only designed for neutrophils, example interleukin 8. Next is CC. All WBCs except neutrophils will be brought by this, like Rantes, T for T cells, MCP1, M for monocytes, eotaxin for eosinophils. And lastly, we have the gamma chemokine, which is going to bring the lymphocytes, example lymphotactin. Now one last thing before we proceed on is that whatever may be these chemokines, any of the categories, how are they going to cause the movement, or how are they going to attract the WBCs? Because they are going to act on the WBCs via receptors. Right? So there is some chemokine that is circulating that is going to act on the WBC on receptors known as the chemokine receptor. Chemokine receptor. And when it acts on the WBC and on the chemokine receptor, it will cause the movement or attraction of that particular WBC towards the source of infection. These receptors are known as CXCR and CCR. Why are there 2 separate receptors? Now what you can visualize, R is for the receptor, simple. If there was a chemokine that had both cysteine and amino acid, both C and X, which receptor will it act on? CXCR. If there is a chemokine that has only cysteine, CC, C, no X, it will act on the CC receptor. So that is the terminology. If it has an amino acid, it will act on CXC receptor. If it does not have an amino acid, it will act on CC receptor. There is one link with immunology that you are going to formulate over here. You do not need to know the names of all the receptors, but definitely remember there is something known as CXCR4. 4 letters, CXCR, so number 4. And the next number becomes 5, so CCR5. This combination of receptors you need to remember. CXCR4, so 4 letters, 4 number. The next is number 5, so CCR5. This particular chemokine receptor is needed for the co-binding of a very important infectious agent, that is human immunodeficiency virus. When human immunodeficiency virus, HIV, enters the body, we know it enters mostly the macrophages and the CD4 cells. But the co-binding, apart from the routine binding, there is one co-receptor that helps. That receptor is the chemokine receptor, that is CXCR4 and CCR5. So students, this was about the cell-derived mediators. Now if you focus, we did two categories. One was preformed, where we had histamine, serotonin and lysosomal enzymes. If we want to do one or two quick questions, then the most important or the richest source of histamine was a mast cell. The richest source for serotonin was enterochromaffin cells in the GIT. Lysosomal enzymes were coming from three types of granules, of which MPO comes from which granule? The primary azurophilic granule. Coming to newly synthesized, nitric oxide had a very important action, that is vasodilation mediated by cyclic GMP. Platelet activating factor is one of the most potent mediators that we had. Arachidonic acid, which was a 20 carbon compound, resulted in formation of prostaglandins by the COX pathway, leukotrienes by the LOX pathway, along with lipoxins. Lipoxins, please recall, had anti-inflammatory properties. Next we had cytokines, which was a long list, of which important ones were interleukin 1, interleukin 6 and TNF-alpha. TNF-alpha is the one that is responsible for decrease in appetite or cachexia. Another very important cytokine was interferon gamma. Interferon gamma is the one, gamma, G for gamma, which is responsible for granuloma formation. And lastly, we did chemokines, which were falling under 4 categories, of which there was a combination of cysteine and amino acids. And we did 2 receptors for chemokines, that is CXCR4 and CCR5, which are important co-receptors for the binding of human immunodeficiency virus.